Okay, well, good morning, everyone. This is the Licensing Task Force Healthcare Subcommittee. It is April 17th, 2026 at 9 a.m. We're going to go ahead and call the meeting to order. And I'm going to turn it over to Aaron Sullivan to do a quick roll call and introduce staff.
Thank you. So good morning, everybody. I will just go down the list and please say if you're here, if you're a subcommittee member and you've just joined and you haven't been promoted to a panelist yet, please raise your hand so we can get you into the discussion. Okay, so we have Tony King.
Present.
Representative Etchart.
Hi.
Senator Harvey. Okay. Senator Nolan.
Here.
Senator Zolnikoff. Representative Seconder. Director Brereton.
Here.
Stacy Anderson, I think she was joining late. Dr. Brewer.
Present.
Webb Brown.
Here.
Representative Buttry.
Here.
Jennifer Hensley.
Here.
Brad Longcake.
Here.
Kristen McCauley.
Here. Sorry.
Amy. Oh, okay, thanks. Amy Narrison.
Here.
Allison Paul.
Here.
Sierra Reesberg.
Here.
Jason Small.
Here.
Gail Tronstad.
Present.
Great. Okay, almost everybody is on this morning. Thank you. So for staff, I'm Erin Sullivan, policy analyst with the legal division.
All these little people, then they keep them still labeled.
Can we get whoever that was to mute? Thank you. With the Department of Labor and Industry and staffer for this subcommittee. And then we also have Lisa Patzer, who is running our technology, and Jennifer Stallkamp, who is Deputy Chief Legal and Legal Counsel for this subcommittee. And then also on the call today, we have Kevin Bragg, who's the Bureau Chief for the Licensing Division. And then I've also asked Missy Portinga to join. She is the Executive Officer for the Board of Nursing. So she is also on the call as a panelist today.
Excellent. Thank you. And again, welcome everyone. Really appreciate your time and attendance here. I know we've had several meetings in the last week. A lot to cover and review, and hopefully some good actions to come out of this. Looking at overall where we are and where we've been, it looks like we're about halfway through this short timeline for this committee to bring forth some proposals. So now is the time to kind of reorganize all of our thoughts and suggestions and start moving forward so that we're prepared to give a report out at the end of our time together. So going down the agenda, subcommittee considerations, item 2A, just kind of reviewing both our April 13th task force meeting and then our presentation last Friday, and then getting together with the whole committee on Monday. Just any sort of ideas, thoughts, anything that we need to highlight, anything that you wanted to make sure that we brought forward so that it did not get lost to the shuffle. So I'm going to open it up to the committee here to kind of state what you think is top of mind and that we should focus on, especially as we go forward. If you would, please raise your hand and then I'll call on you so we're all not talking together. I'm not seeing any hands raised. No? All right. Again, appreciate all of the comments, everything that we're doing. I know a lot of this is volunteer time, or all of it's volunteer time. So please keep the ideas coming. Please let us know if you're hearing from folks out there in your communities about what we can do to help ease the burden. But with that, we'll move on to the second item on the agenda. We're going to discuss administrative burdens, just do some follow-ups, and I'm going to turn it over to Erin here to kind of present some of what she put together.
Thank you. Chair King. So I'll go ahead and share my screen. And what I'm going to do is I'm just going to go over these two documents that were sent out on Wednesday. They're also posted to the website, and these are, hopefully you all remember, these were follow-up data requests based on one of the meetings that we had. And so we were able to pull some additional information together for everybody, and so I wanted to share it if I can. Screen 3, here we go. Okay. So this first one is the healthcare licensee cost of licensure. So if you recall, at the March 13th meeting, we reviewed the healthcare licensees and application information as far as the number of applicants and the time to licensure. And there was, I believe we had included the cost of an application for each of the different licenses. And a follow-up question was examinations and how many examinations there are, cost of examinations, stuff like that. And then at some point, somebody had requested some wage data and if there was a way that we could find the average wages for each occupation in Montana, compare it nationally and all of that. So this is a follow-up to kind of combine the rest of that cost of licensure information that this committee has requested. So you'll see that for each of the healthcare, and I'm not going to go through this whole thing, but for each of the each healthcare license, we've got the current number of licensees and the cost of a license application, which is what you received on that other document, but it's on here again. And then educational requirements and cost of licensure examinations, the number of exams required. And then it does indicate if it's a national exam, then and what the accreditation body is if it is a national exam. And then we've got as much wage data as we were able to compile. And so just going through, and again in alphabetical order, so you can just kind of read what this says. So for the first one's Board of Allied Healthcare Professionals, you can see in the blue box over here is the number of licensees and wage data. And then the cost of licensure is in this middle column that says for a clinical lab scientist, for example, an application is $100 and the examination is $260. And then it shows there's only one exam required for this occupation, and it's a national exam, and all of these acronyms that I don't know what those are, but that's who can administer the exam. And then for education pathways, you can see how what education is required for this position. So this is, and then you can see right here under lab technician, there's a couple pathways. So you have to have one of the following. So all of that information is provided, and hopefully this gives you kind of a comprehensive picture of the cost of a particular license. I did want to, if I can find my email, Hugh Pratt is the one in the licensing division who compiled this information. And let me see if I can get the right email. He did have some explanations on this data. And so I'll just kind of read through the key points that he had. So the wage data was provided by our economists within workforce services, but it may be unavailable for several reasons. One, the profession is primarily composed of independent contractors, which makes wage data difficult to capture. Two, the license type applies to a business rather than an individual, so we wouldn't have wage data for that. So I believe I can scroll down to like the Board of Pharmacy. There might be some facility licensures to get down there. And then, so here, limited service pharmacy, obviously there's no data available for that, for mail order pharmacy and all of that kind of stuff. Or the profession includes multiple distinct occupations. So for example, contractor licensing, which is not on here, but that is the example that was given. It could cover masonry or carpentry, each with its own average wage. So the average wages don't discern between junior and senior licensees or licenses. So for example, an addiction counselor candidate and licensed addiction counselors, they don't have the same wage, but the data is based off of the ONET code for each of the professions and candidates, or other junior licenses, they don't have specific ONET codes. And so if you see an asterisk, actually, I'll go back up to the Board of Behavioral Health, because that was the example that was given. So right here, licensed marriage and family therapist candidate, see how there's an asterisk there? So if there's an asterisk next to that, that is one of those occupations that falls into that category that I just explained. And then some license types are indicated are endorsements of a full license. So for example, the impairment evaluator license is an endorsement on the chiropractor license. So that endorsement is not going to have the same, or it will have the same wages as the chiropractor. And so besides impairment evaluator, the other endorsements listed on here are clinical pharmacist practitioner and pharmacist preceptor. And then some license types don't have a specific ONET code, but a generic code. And I believe that the examples given in Hugh's explanation, none of them have to do with healthcare licensing, but there are some license types like boiler licenses where it's one code for every type of boiler operator classification. So then let's see here. What else did he have to say? So the license counts reflect the data that was pulled, or data was pulled on April 9th, so it's very current. And the original goal was to identify the most common educational pathway for each license, but that wasn't feasible, or because it wasn't feasible, they instead listed the full range of educational pathways. And that'll provide you with an understanding of the time and educational investment typically required to enter each profession. And examination costs were sourced from exam agency websites or from board and program rules. And the number of examinations column or section, I guess it's not a column anymore, indicates how many separate exams an applicant must complete. For example, an architect must pass the ARE, which consists of 6 individual sections taken at different times. So lots of good explanation on this data and how it was compiled. And before I pass it, let's see here. I don't think that I had anything for Kevin to chime in on this document. So before we move on to the next one, does anybody have any questions or comments? No?
Specifically
Okay.
Sorry, Aaron. Like I reviewed it, looked at it, and I didn't see any sort of like there wasn't a very big outlier for cost of licensure or anything that I looked at that I saw to be burdensome. Obviously, everyone wants their license and examination fees to be as low as possible, but I didn't see anything that I would have deemed a barrier into entry into that profession. But I'd open it up to the committee to see if there was anything that stood out to them. Okay, Aaron.
No. Okay. So the next one is this is a very small update to this board composition data request that the committee asked for at the we must have given it to the committee at the March 13th meeting. So this document should look familiar to everybody, but one question was asked as far as when talking about the board composition and number of members on the board, how many vacancies there were. And so we will so this again looks exactly the same unless you can see right here, Board of Behavioral Health. If you see anything in red, then that's the update to this document that we provided. So for example, on this board, there are 2 vacancies currently. And there is going to be, and I think Kevin talked about this at the last meeting, but there was a statutory change regarding board vacancies reporting, I guess, on the biennial report that is issued to the governor's office every 2 years. And so this year is one of them that is asking for board vacancy information on in that report. And so when that report comes out later this summer, this kind of information will also be included on that. But we just wanted to provide you with the basics, and so you can kind of look through and see which boards are fully appointed and which ones. So here you can see health. There's 1 out of the 3 board seats for a massage therapist is vacant and the public member is vacant. So 2 out of 5 vacancies for board of massage therapy. Again, I think this was kind of information that you guys were interested in looking at and reviewing for a discussion that we decided to put further down the road as far as solutions or not solutions, but recommendations for administrative burdens regarding healthcare licensee boards. So hopefully that information is useful to you. And there was another, while we are on the topic of boards, another question that was asked at the last meeting was, what's the burden on staff as far as preparing meetings, the board books and all of that kind of stuff. And so I'm going to pass that question over to Kevin because he was able to get some information regarding that. And so just so you're aware of the hourly burden that a board meeting has for staff. So Kevin, if you don't mind.
Yeah. Good morning, Chair King, members of the task force. Thanks for being here, all your important work. One of the things that we've been previously asked was the time commitment for staff in preparing for meetings. That's a big question. Specifically, if we're talking about like substantial equivalency, which was updated in 2025, thanks to our legislature, when we're putting together requirements for all 50 states, that can be a very time-consuming effort. And so what we did was we asked our staff to limit the description of the time that I'm going to give to you to scheduling, board book creation, which is the documents that go out to each of the board members, the actual meeting facilitation, and then post-meeting follow-up. So I'm going to give you some broad numbers. I do have actual data on this. I'm happy to put that together if that's helpful for the committee, but just give you some broad overview of that. We also did this undertaking with our compliance team, which is a separate area from mine. It's underneath Quinlan's shop, but the full board statistics were it takes approximately 45 to 55 hours to prepare for a full board meeting right now. And why I say right now is because, again, in 2025, you'll know or recall that we undertook several legislative changes, including one of those was taking non-routine application review out of full boards and pushing it to screening panels. We don't have enough data to really go off of right now that I could tell you. If you were to ask me a year from now, I suspect that number will be lower. How much lower? I can't imagine it would be a ton lower because our non-routine application numbers are generally relatively low right now. But again, for our average preparation time for full board meetings is about 45 to 55 hours. And then for the screening panel component, and again, for those of you who aren't licensing lovers, screening panel is our compliance setup. And so when a complaint comes in, it goes to the screening panel, assuming it's not administratively closed. That screening panel is comprised of half of our licensing boards or a department staffer if it's a licensing program, and they get together and meet and review those complaints. After screening panel is the adjudication panel. I don't have numbers on that, but Jennifer Stallcamp's on the call. I'm not going to call on her specifically, so don't freak out, Jen. Adjudication panel is usually a lot quicker because there's not as much review going on. But for our screening panel time, we got to a number of about 20 to 25 hours. So screening panel meetings right now take about 20 to 25 hours to get prepared. Again, if you were to ask us in a year and if there was a significant increase in non-routine applications, which I don't expect, that number might go up. So again, for full board, it's around 50. For screening panel, it's right in between 20 and 25 hours for each of those meetings. And again, that doesn't include necessarily research time, which can be a hard thing to peg down to an average. So I hope that's helpful for you as board members. Again, if you want to see some of the actual surveying that we did of our staff and how we comprised that, happy to give that to you if that's beneficial for you as the task force. But that's just kind of a broad overview.
Thank you, Kevin. To your knowledge, going back to the vacancies that are here, have any of the vacancies on these boards led to a delay in licensure? Have they led to, like, I don't know, having served on a board like this, I don't know of anything that, we didn't cancel meetings because we didn't have enough people or anything like that. But for this committee here, I think we're really interested in seeing if that was adding into a length of problem for people getting to be able to work.
Yeah, great question, Chair King. We do have times where we do not have enough board members to field a quorum. And that at times does delay our ability to issue licenses, specifically those non-routine licenses. You recall that routine licenses department staff get to issue. But for non-routine licenses, if we don't have enough members that are either available or appointed, then we can't have meetings to either review applications that are non-routine or adjudicate compliance matters. And so at times that can become a burden. It's not very frequent, but it does happen.
Thank you. Webb, go ahead.
Thank you, Chair King. A couple of things directly on that one, if I could. I think this was addressed, I think, in the 2023 legislature too, that one of the concerns about board members was vacancies. And I don't know that I've ever seen that circumstance in the Board of Dentistry. I've only been around, basically involved in it 4.5 years, but I think that's, I don't know the validity of that being an argument. If I could ask a question to Mr. Bragg, related to the staff time, if I understand correctly, that staff time is allocated and charged to and paid by the board, correct?
That is correct.
And Mr. Chair, if I could follow up on that
Sure.
as well. So not a question, I guess. So the licensees are paying for the staff time, correct?
Everything I
Bottom
do
line.
is funded by your licensees.
Yeah. Okay. Just, I think some people may have the wrong impression that if they reduce some of this, it's going to save the state money, and that's not accurate, in my opinion. So thank you, Mr. Chair.
Chair King, if I could go back just briefly.
Sure.
One of the other things that I neglected to mention, I apologize, was we have a correctional healthcare review team, and I think they review specific complaints from prisoners. Did I get that right, Jennifer Stolkamp? Erin's shaking her head. Yes, I think I got that
Inmates
right.
is probably
Inmates.
better.
Yeah, thank you. And then that takes, again, about the same average amount of time, 20 to 25 hours worth of staff time. And Jennifer may be able to expound a little bit more if you have interest in that subject. But Misty did pass that information along to us.
So if I could just piggyback on that, Chair King.
Please.
Okay. One unique thing about the Correctional Healthcare Review Team, or CHCRT, whichever one is easier for you to say, is that currently it is not a standing board. It is, or review team. It has a different makeup each time there's a need for it. And so if you look, and I don't know the statute off the top of my head, but there is a statute in there that talks about CHCRT, and the basically it asks for volunteers to sit in a pool, kind of like a jury pool. And then when there is a need for this team to meet, then we have to pull people together to get that to get that group of folks to review these complaints. And basically, it's a review of a complaint from an inmate against a healthcare practitioner that treated them, and it's just a review of the complaint to see if it warrants moving to the full board. So why we wanted to bring that up is that even though there's significantly less number of complaints and meetings and stuff with the CHCRT, it still takes the same amount of time as a screening panel would, because of the time it takes to establish the necessary review team members. So that's what we wanted to pass along about CHCRT.
Okay. Other questions? Go ahead, Kristen.
Hi, thank you, Chair King. With regards to the CHCRT and kind of that, not review board, but review team, um, is that just then for the correctional systems like DOC, prison, the people who've been sentences and away? Or is there any part of that that oversees that in-person care that they're receiving in the detention center? Because they're getting meds there, they're obligated medical care. And so I want to know how that correlates maybe with the county detention centers.
Um,
Do you want me
Jen,
to
you
answer
want to
that?
go?
Okay, I'm happy to, Erin, unless you want to. The statute provides specifically filed by an inmate for services provided while the person was detained or confined in a county detention center or under the legal custody of the Department of Corrections. So we do review complaints from county inmates, but there's not like a proactive sort of monitoring of county services, if that makes sense.
Thank you. Follow up on that then. I work in a county detention center, have a lot of connection, interaction with inmates, both in the county and held for the DOC. The jails are obligated to provide medical care. That medical care is usually by a contracted somebody. And then they're also given medications. And right now there is no certifying process or license type that I can see that's specific to that location. And if it's taking just as much time to put together a screening, just as much time to put together the CHCRT review team, I think it might make sense to have a board or panel of sort to review those situations and encounters.
Maybe I'm not clear on which situation, like the CHCRT doesn't review until they get a complaint. So
Oh,
what?
so they're so rare that you don't have very many.
Correct.
Okay.
The CHCRT was originally set up to sort of do a pre-screen of complaints coming out of inmates, so there wouldn't be a flood of, nursing board
Good call.
complaints.
Good call.
So they come together, and to add on Erin's explanation, if we get a complaint against a nurse at the prison, for example, the CHCRT team would include nurses. So it's not, we don't have social workers reviewing nursing complaints.
I think
We
a
have to
real
get.
potential gap in that is
Yeah.
that the administration of medications in a jail setting is not by a medication aide and is oftentimes not by a nurse.
Yeah, and that again it's a complaint-based process. So it would be a larger discussion probably with Mr. Strauss on behalf of the Department of Corrections on what that looks like in settings.
And I present this not as a area of concern, like I think it's largely going okay, but as we look at and it's maybe pathways to licensure and a little bit further down in the agenda, and there was talk in the full board meeting about CNAs and the licensure there and how they are our primary pipeline into nursing and the nursing shortage and increasing our professional licensure. That I think there's an opportunity to license a group there so that we can have a safety protocol, a way to receive complaints against med assistants or the people that are administering the medications in those settings that are more aligned with nursing.
Okay.
Thank you, Chair King.
Other questions, comments regarding the data requests that we've asked of Aaron and department? Aaron, go ahead.
Are you waiting for me for something?
Yeah,
Or-
I think
Oh,
I think
sorry.
this is a good, so, and I'll just preface, we've asked a ton of Aaron, we've asked a ton of the department, we've asked a ton of group trying to gather data. Um, we asked about burden of putting together meetings, and I think we've burdened them with putting together several meetings ourselves. So in discussions with Aaron and others, we need to kind of, is this all we need? Do we have any final requests? Can we just go with what we have, make our, obviously we're going to have a few more meetings, but if there's any other data requests, it takes a ton of time for them to put this together. So I think we need to kind of have a final data gathering request and then be done. Aaron, before I have them ask questions, did you want to comment or?
Yeah, that's thank you. And we just talked and I told you I was going to mention that and then I completely forgot. So yeah, just in the interest of efficiency and time and also some relief for Kevin's staff because they are the ones that are compiling all of this data. It's really good information. These are great questions to ask. However, if we could maybe get an idea from the committee about what you think you're going to need to move forward on this administrative burden topic to maybe make some recommendations at the June meeting, I think is when we kind of rescheduled to, or decided that we were going to pick this topic up again. It would be very helpful for us if we could get that information now and so we can start compiling it because as you all know we have more than one subcommittee and everybody is interested in the data and the information, which is perfect. That's what we need to be able to present that to you so you can make good good recommendations. But if we could just know now, that'd be great. And you don't have to like say it out here. If you want to email me or call me in the next week or so, then that's fine. But I did want to just make that ask for our staff.
Thank you. Webb, you're first.
Thank you. And I'm very cognizant of additional requests of Ms. Sullivan and try to keep those limited. But I think you mentioned one earlier, Mr. King, that I think is critical to the premise of this task force. How many people are actually not getting a license that request one? And unless it's been provided and I missed it somehow, I know we've gotten a ton of information, but if the idea is that there are Montanans who want to practice under some licensure, but are not able to do that, and I'm not talking about the folks who, what we refer to as a chilling effect, if they don't even apply, but how many licenses are actually being denied? And we talked a little bit about sometimes a license isn't provided because the licensee, the applicant, excuse me, doesn't complete work, but how many are literally denied? I'd still like to know that, and I don't think that would be a major heavy lift, but unless Ms. Sullivan, correct me if I'm wrong, if it's already been provided. Thank you.
Thank you, Chair King and Webb. I think that we've had discussions about it. I am probably going to punt this back over to Kevin because I think he gives the best explanation on it. But I don't think that we haven't produced like a document that says this. But we've definitely had this discussion either at this meeting or a different one. Kevin, do you want to add to that?
Sure. Thank you, Chair King and Webb, for the question. Again, I think I've said it previously. We're happy to provide that information. It's going to come with a heavy lift of assumptions. related to whether or not an outright denial is the ultimate purpose of the task force. I mean, certainly outright denials are an issue. They're a very minor issue. I'll be clear with you on that. Having said that, the time that it takes to get to those and whether or not an outright revocation of a license nullifies the intent of the task force, I would encourage you to look at whether or not we can make licensing quicker and more efficient and figure out what we can do as far as reviewing existing regulations, even though the numbers for outright revocations will be low. Having said that, in order to look at denials, you need to help me with understanding how you want those framed out. Are you talking about actual revocations or denials from the board? Or are you talking about going back and looking through applications where they're withdrawn by the applicant? Or there's some other issue where somebody drops out of the process? Because some of that information, obviously, we won't be able to get. But if you're asking for just how many licenses are revoked or denied by boards, we can certainly provide you with that information. It's going to be a low number. But I think what we're doing here and what the collective good of the task force is trying to figure out where we can improve outcomes for everyone else, not just look at the grand picture of whether or not there's a large number of people being denied or a low number of people being denied. I think that's probably what I'd have to add, Aaron, but we're happy to provide that information, Webb.
And I'll turn it back to Webb here to clarify, but I don't think he's asking for people that have had licenses and had them taken away, because clearly there was a reason for them to be taken away. I think what he's asking for is the people that had submitted an application, but probably two things there, Kevin, is those that withdrew them themselves, there's not a lot we can do about, but either the department or the board decided they're not going to grant an initial licensure. I think those are the two questions. Webb?
No, Chair King, that's exactly right. And thanks, Mr. Bragg, as well. No, I'm definitely not looking at revocation. It is, and I go back to when the governor first launched here and talked about the 100,000 Montanans who were not working. And were we going to make it easier for them to be able to apply? Well, obviously, they have not even applied yet. Well, I shouldn't say that because they may have and been denied. But I agree, it's a low number. When we've doubled the number of licensees, again, back to the governor, I'm paraphrasing, so don't quote me, even though I guess it's being recorded. It just, it doubled what, in the last decade or 15 years, whatever. It doesn't seem like licensure is the barrier. And you just kind of said it yourself. It is a very low number that have been denied. So I'm going back to the premise of what we're trying to accomplish here. I agree making it easier once you apply, but if almost everyone who applies is getting a license, I just don't see the barrier here. I don't see that the licensing is the issue, but maybe I'm missing something. Sorry, rattled on there. Thanks, Mr. Chair.
Chair King,
So
if I could,
yeah, I was going to say,
I don't want to get into a back and forth. I certainly appreciate the perspective. I mean, the things that we're looking at broadly as the task force are trying to identify and remove burdens or barriers faced by licensees that are not necessary to protect the public. And then also improving access, which means expanding the number of people who are getting licensed and able to come into the profession. And so I think the validity of the task force is certainly appropriate. The work that you're doing is impactful, and we need your help in order to expand our workforce and again continue to look at our rural and frontier communities so that folks aren't being penalized for where they choose to live in our great state. And so we'll certainly be glad to provide that information and appreciate the context, Webb. Thank you.
Kristen?
Thank you, Chair King. This comment kind of frames the context of what we're talking about with barriers that when they're not being denied, but then also lead into where you're at with the license type barriers. So I don't know if you're ready to move on, but it links the two. So when that's ready. my comment would be then that as we look at barriers, we're wanting to improve access to people. We have a significant nursing shortage, but we also want to look at broaden maybe how we're defining barriers. That's not just not getting a license, but like license barriers aren't just about getting nurses and MAs and providers into the workforce, but also where and how they can function. Like for the instance of the medication aids, they can only provide services in a long-term care facility, an assisted living facility. And as our rural population, as our Montana population ages, we have more and more advanced age, more and more people needing medications, more and more people providing home services and administering medications that aren't family members, that aren't licensed to do so. But it is a licensing opportunity where we can broaden the licensed skill force, provide more licensed paid positions, and the barrier where in the MCA 37 on some of these limit the location of where the practice can be performed, which limits and is a barrier to people pursuing a license type, and is also limiting access or services of our constituents that our age populations really need. Thank you, Chair King.
Aaron, did you catch that so that we can?
Mm.
Yeah, thank you.
Yep. And did you, Chair King, did you want me to kind of explain the sub 3 topic? Okay.
Well, hold on. I just wanted to open up to others that may want to bring up an individual license type barrier
Yep.
that may not have. There.
Oh,
Okay.
yeah, I meant sub 2. I apologize.
Okay. Thanks.
Yeah, if I could real quick just explain this, and I put it in my email that I sent out on Wednesday to maybe start thinking about this and be prepared for a discussion today. And again, you don't have to, if you can't think of it now, it doesn't mean that you that you lose your chance. But basically at a prior meeting, there was a request to maybe do a survey just to get some feedback from everybody on what have you heard in your community or in your industry or whatever about an individual license. So Kristen brought up a great example. So for the medication aid, that is one type of license, and a potential barrier with that license is that they are only allowed to work in certain settings. So that's just an example. If there's other ones that you have specific to healthcare licensees where you have heard either from an employer or from a potential licensee or an existing licensee that, hey, this is a barrier for this license type, then that's the kind of information that I'm asking for right now. And again, if you don't have it or if you can't think of it on the top of your head, then you can certainly call me or email me with it in the next week or so. But really wanted to kind of drill down into some of these individual licenses and specific barriers to those licenses.
Thank you, Aaron. Sierra.
Thank you, Chair. One question I think that might be worth considering is how many candidates for licensure don't fully become licensed. It might be an interesting data point of those who aren't completing the requirements in the candidacy to be eligible for the full licensure. Like, are they giving up? Are they losing interest? Like, what's that barrier holding them up there?
Okay. And I think that was a question from Webb as well that we clarified with Kevin. Maybe when he reports back, we can see how many people started but then withdrew. I'll for this discussion, I'll just throw this out, and it's not healthcare licensure related, but I have a friend that wants to start being a fishing guide, but they're not allowed to be a fishing guide until they do a certain number of hours under somebody else. And to me, if you know how to fish, you know how to fish. So it doesn't make a ton of sense, but that's the kind of stuff that we'd like to hear from now. If you're hearing from people either in your profession or in your community, whatnot, that are specific to our healthcare licensure, or we can throw it to a barriers committee or something like that. Now's a good time. There will not be a survey goes out, but Aaron's happy to take any sort of comments here for a bit as we plan our next meetings out. And there's a comment posted in here in the chat from Serena about like insurance credentialing. I think that's a very relevant and important topic that we probably should hit on in a future meeting, that we need to probably recommend that there be a very good look, if not some sort of legislation that requires these insurance carriers to act a little faster so we can get them in the workplace. Representative Buttrey.
Yes, thank you, Mr. Chair, and maybe Aaron can provide some clarification here, but when we started these efforts, I had brought up an issue that had come up from one of our healthcare facilities, and that dealt with provider licensing verification. And in past years, I guess they have to verify the provider licensing. I don't know if it's monthly or quarterly or whatever it is, but they would go onto the state website and they could simply download a large batch of provider data that would show the people that are still in good standing with licensing in the state. At some point, the state updated the process to involve a CAPTCHA. So for every provider, they have to go in and manually put in data and hit the CAPTCHA. So they have to do it one by one by one by one, which is incredibly time consuming and burdensome for the healthcare facilities. They were wondering if we could go away from that CAPTCHA or use something else where they could download the data in one sort of mass fashion versus doing it individually. And I know, Aaron, we've talked about that. Did we ever address that, or is that planned to be addressed?
Yes, thank you, Representative Buttrey. I'm going to pass that over to Kevin.
Chair King, Representative Buttrey, thank you. It is an issue. You can still download a list of licensees. It's a licensee list, and you can select what statuses. That is a tad bit tedious. One of our efforts here at the department is trying to figure out how we can improve our licensee lookup. If you have used that system and you've done a single person search, you can see how onerous that is. That licensee lookup list can be an easier way for providers to look at the full listing of active professionals or even expired or terminated licenses for boards. However, we are looking to improve our licensee lookup. One of the things that we're frequently asked at the department is, can we build an API into Acela, which is our licensing database? And I don't remember what API means. It's an interface between two systems. The problem with that is there are so many different providers and systems that building APIs for every single requester with state resources and licensee money is impractical, but that downloading the full licensee list may be a little bit of a workaround about that. But licensing lookup is something that we are looking to improve here at the department, and certainly I think an appropriate topic for the task force to evaluate.
So thank Mr. Chair, Mr. Bragg, thank you for that. I appreciate that you're looking into that. Just one follow-up question. So if you're downloading that massive list of licensees, is there a current way to filter that by facility? So let's say you're St. Pete's here in Helena, you could say, I want to see all licensees for St. Pete's.
This is a great question, Representative Buttrey. I apologize, Chair King, Representative Buttrey. Great question. We are not tracking organizational employers. Certainly professionals can update our system to list which organization they're currently with, but it's not a required field when you're applying for licensure. And certainly as providers move in and out between facilities, that list may become a little bit stale or stagnant. So that is one thing that would be difficult to do, is to track by a specific facility.
Okay, thank you, Mr. Chair, Mr. Bragg.
Not seeing any other hands raised.
Okay. Well, I will again open it up to anybody who wants to speak afterwards, or if you think of something specific in the next week or so, please let me know. And yeah, we can definitely add individual licensee, discussions to the June meeting or July meeting.
And I'll also reference for those that are not on this committee but are in attendance that may have some specific, we will open it up to public comment here at the end. So if you have one that you're thinking of that we haven't addressed or discussed for us to maybe review at a future meeting, please go ahead and bring that forward at the end of the meeting here in public comment.
Thank you.
Agenda item 3, then, identify issues for a future meeting. I think this is as good a time as any to look at our work plan and the meeting schedule that Erin has laid out. I'll turn it over to her.
Oh, thank you. I don't have that up.
I
So
didn't either.
it's
I didn't either. That's why.
it's fine. It sounds like the nobody had any updates based on the meeting that we had on Monday. And so let me just pull that up real quick. That's the agenda. I am sorry. I think we were, if everybody is still okay with this schedule, we're going to start our topic of pathways to licensure today with the interstate compacts, and it'll just be, and we'll go into that in just a minute. That'll definitely need a follow-up, is my guess. And so for the May 15th meeting, I have some that we would focus strictly on pathways to licensure, which was your second big topic that you wanted to cover. And so that would be, we can continue on interstate compacts. We can work on the RHTP Initiative 1 tasks if need be. And then and then I can put together some sort of discussion on expanding pathway options. And the things that are listed, like the subpoints listed in the work plan for this, are apprenticeships, endorsements, full scope of practice, out-of-state provider utilization, and telehealth. So we'll try to come up with some good resources for all of that to hopefully have a good discussion on the 15th. And then the idea was to get that topic started and then continue to work on it in June, but also go back on the June 12th meeting to the administrative burdens. And so then I guess you have, almost 2 months to get me the whatever you have as far as individual license barriers and that kind of stuff. But again, the ask is that if I could get the information or any kind of data requests sooner rather than later so we could get those prepped for you timely, that would be great.
Committee members, other things that we're missing? Kristen?
Thank you, Chair King. In the RHTP presentation and then comments at the full task meeting, did we need to address anything else other than full scope of practice, interstate compacts within our task force in this subcommittee? Like, I think CMEs were talked about.
Yeah, I
good,
could.
good clarification. Go ahead, Erin. You can.
Oh, thank you. Yes, I will. So with the nutrition CME for physicians, that initiative or whatever you want to call it with the RHTP, it's a little preemptive to discuss it at this task force meeting because the Board of Medical Examiners is currently working on this. So they do have a meeting next week and it's open to the public. I think it's Friday. I think it is next Friday. And I know that is on their agenda to discuss. And so I didn't want to put it on this agenda before the Board of Medical Examiners was able to continue their work on it.
If I may, when I read the thing about physicians, and I don't know, I need to go look how our MCA defines physicians, but I believe that to be anybody who practices medicine. So I didn't think when I read that, I didn't read it as inclusive of just physicians. I thought that was broadly any prescriber. So I don't know that I don't know, just for point of conversation when that comes back up.
Yeah. Hey, this is Charlie Brereton, Director of DPHHS. So, Kristen, if you look at the CMS Rural Health Transformation Program Notice of Funding Opportunity, it only speaks to physicians. And so our interpretation is that it's physicians only, setting MCA aside.
Okay.
Director Barrington, you're referring to MDDO designations?
Correct. Yes, MDs and DOs.
So we can certainly provide an update to the committee at the next meeting. But again, just thought that given the timing of everything, and I believe Director Brereton mentioned that the DPHHS would be presenting at the Board of Medical Examiners meeting next week. Didn't really think that that was something that this task force needed to address urgently.
But good
Thank you,
clarification,
Chair
Kristen.
King and
Yep.
so
Okay. Any other things? And again, I know in the chat here, there's been several comments about insurance. It is in the parking lot, but I do think it's very relevant and very, perhaps it's a recommendation that we have a different task force or something. But I do agree that that's probably as limiting to this state and healthcare as anything else that we're going to touch on.
Okay.
We ready for C?
Yes.
Okay.
Okay, so I have just I submitted or posted a lot of just kind of reading materials for you guys to mull over. Like I said, we're going to start this interstate compact discussion today. We weren't able to get a presenter for today's meeting, and so that's why it'll be good to carry it over into the May meeting. So what I put together for you, if you wanted to look, I'll share my screen. That's what I meant to do. There we go. So this document that on interstate compacts, what I did with this is I just pulled this information. These aren't my thoughts. This is the Council of State Governments, and I can't remember what National Compact Commission or something. They have some, it's called NCIC. They put together all of this information. There's tons of different websites for each of the compacts, but most of it does run through the Council of State Governments. But this is just the information that's on there that talks about what compacts are and some benefits for compacts. So I'm not going to read through that for you guys, but I did also include what compacts are available. So there's 20 for occupational licensing, and and we have joined the majority of them. And so you can see on this chart right here, it shows the different compacts. And then the year that we joined, you can see there was quite a few in 2025. So we had dietitians, massage therapy, PAs, and psychologists and respiratory therapists. So 5 compacts were passed by the legislature last session. And then these are the ones that are not enacted right now. And I think, yeah, you can see that most of them are healthcare related. There's a couple that aren't. So cosmetology is not what we consider in our healthcare licenses, but that is a compact that's available. And then what were the other ones? Oh, I put in here school psychologists and teachers as well, just because I wanted you to see all of them. That are available. And then the next pages go through just for each compact. So these are just the compacts that we are not a part of, that I wanted to provide resources on. And so the APRN one is the only one that didn't have a nice map. But basically what each of these pages show is the compact, and then there's the status. And so 7 states for compacts, if you have to have 7 states join a compact before it can actually become enacted. And so for the APRN one, it is actually not in effect yet because there's only 5 states that have passed legislation, and you can see the years. So starting in 2020, and the last one was South Dakota, just this last, or 2 years ago, I guess. And then I also provided, if there were resources available, I provided some links. And so this is a good living document that provides a lot of web links for you. So athletic trainers, you can see again, this one, there is actually, there's only a couple. This is not correct because there are some other states that have passed it recently. And so, but you can find these, all of these maps on, if you go to the footnotes, that's where I provided the link to the actual compact webpage. So athletic trainers, there's actually 5, I think now. A lot of these light blue ones have actually, they've passed legislation this year, and so they've turned dark blue. And then cosmetology, you can see that one is just recently, I guess, enacted. There's more than 7 states. So I think out of all of the compacts that are available that we haven't joined, the only one that may not be ready as far as the number of states would be the athletic trainers and then APRN one, I think. So you can see for each of these, there's, some of these compact websites have more information than others, but I did want to just provide as much of the resources as possible so you could see the model language if you wanted to look at what the model language looked like or anything like that. So specific to this committee has talked about EMS. So you can see right here, all of these dark blue states have joined the compact. So there's this one is in effect. And then there's some fact sheets and I also provided some links or some actual PDFs of the fact sheet and some other stuff for you guys regarding the EMS compact. This one is, I don't think 1, 2, 3, 4, 5, 6. Okay, so it doesn't look like the podiatry compact is enacted yet because there aren't 7 states. And then same with school psychologists. So I lied. There's more than just the APRN one that is not in effect. So the social work compact, there was a bill last session to enact the social work compact in Montana. It did not pass. And then the APRN one is the other one that has been attempted. As far as I know, those are the only 2 compacts that have been attempted with the Montana legislature and have not passed. So before we go into any more of a discussion, I did want to have Missy kind of speak a little bit on the status of the APRN compact because that is one that I believe the state has tried 3 times and there's been and it has not passed any time. And she gave me an update on the status of that compact. And so I just wanted the committee to be aware of what's going on with that specific compact. If that's okay, Mr. Chair, if Missy could speak.
Thank you, Mr. Chair and members of the committee. My name is Missy Portinga for the record. I'm the Executive Officer of the Board of Nursing here in Montana. The APRN Compact has had a number of iterations since the late 90s. The current draft language was approved by all of the states through the National Council of State Boards of Nursing in 2020. It's been introduced here in Montana 3 times. And it hasn't passed, obviously in all 3 sessions. This information from CSG, Aaron and I were discussing it the other day. I don't believe Wyoming has actually enacted the legislation, so I do believe it's only 4 states that are in that compact currently. So because it's not gained the traction that we had hoped for, there have been similar concerns that have been raised here in Montana during the hearings for it. Specifically about it not being a licensure only model. So the current proposal is to revise it. So the draft legislation's been pulled from the website and we're pulling the states together to revise to make it more of a licensure only model so that it's not addressing scope, not having a transition to practice period. Those have been the 2 big issues that have been raised by stakeholders. The vote on that maybe this August, but more likely next August. And for that reason, it would likely not be ready for legislation, obviously, here in Montana in the 2027 session. So I hope that's helpful information, and I'm happy to answer any questions.
So, okay, thank you, Missy. I appreciate that. So that is what this document is and again, we are hoping to have some folks, or at least one representative from the EMS Compact Commission, speak and give some updates on on their work that they've been doing in Montana for that compact, but they were unable to make it to this meeting, and so we can move it to the May meeting and have them as well. And the other one that so you can see, so yeah, I provided some just general resources for compacts and some publications that CSG and NCIC have put out. And then also in your packets that I sent out, I had this one pager from the EMS compact that just it talks specifically about it and the states, and it's just their fact sheet. And then the other document that I provided was from for the social work compact, because that the National Association of Social Workers, they have, I believe they might be on the call, but they're willing to come and present at the next meeting as well, to talk about the social work compact and the need for it to be reintroduced next session. It was introduced, like I said, in the 2025 session, and I believe it was the Senate Public Health Committee did not pass it. So
Go ahead, Webb.
Thank you, Mr. Chair. And I'll speak specifically to the dental compact, and Mr. Longcake may want to get ready on this too. There have been just a little bit of background on this. In part, Montana had considered this in the past. There were competing versions, competing compacts, which makes it very difficult to move one forward. However, the one that we're looking at that Aaron provided, the DDH compact, is in effect. It had 12 states, as you can see, and I think there's a number of others that have legislation possibly moving forward. Whereas the competing one at this point has 2 states that have adopted it. And Ms. Sullivan, you may have to explain to me, they're listing on their website that they only need 5 states to initiate a compact. Is that kind of according to the compact, or is there like national legislation that says it has to be at least 7 states or whatever? I'll let you pop in there.
sure. Thank you. And Chair King and Webb, the individual compacts language will specify how many states
Okay.
are needed before it can go into effect. The average or typical one is 7. So I didn't know that the dentist and dental hygienist one was only 5. So obviously that makes it a little easier to get things going if you only need 5 states to join. But typically it's 7. So
Yeah.
but it will
And
specify in that language.
And to clarify, they're both dental and dental hygienists, but the other one is a national board is sponsoring it, and they're the one that only has 2 and only say they need 5, but the other one is already authorized. So, but to that point, then there have been some recent developments. Some of the issue between the competing compacts was what exams were allowed, and there just Wednesday, I believe, was released information that they are now accepting both are accepting the exams that were kind of the hiccup between the 2. So it sounds like there may be the competing one may go away. And that would probably, and again, to Mr. Longcake, I don't know on the hygienist, but it may make it more acceptable to folks in Montana to approve the other one. However, bottom line comes down to funding. American Dental Association had provided a grant to this effort to get the compact basically established and get the minimum 7 states, and like I say, now 12 to approve it. But now it will shift to how the states are funding that. And that was one of our questions in the past session as well. Who's going to pay for this? Is it going to be, back to my question, Mr. Bragg, is it going to be the licensees? Is it going to be the applicants who want to participate in a compact? And I think that's where the rub will be of whether we decide to sign on to this or not. And we haven't gotten that information yet. I don't know that we've even asked the board to take a look at what it will cost for Montana to participate in that compact. Thank you, Mr. Chair.
Thank you. If I could, real quick, I am forgetting everything today and I apologize, but I did want to have Kevin join in this conversation because there was a question from one of the task force members or committee members on implementation processing and, kind of how things are going. As you can see, I'll scroll back up to my this page right here that shows when we join these various compacts. You can see, like I said, there was 5 last session, but in 2023 we had audiology and speech language pathology, counseling, and occupational therapy. I think those were the other ones. And then, so very recently, we've joined most of these compacts. But there's a lot that has to happen after the bill is signed and goes into effect. And so I did want Kevin to kind of give an overview of what the licensing division has to do once these compacts are passed in the state, and kind of yeah, basically like the nuts and bolts, so you understand. It's not an immediate process. Kevin, if you don't mind.
Chair King, members, apologies for haunting you again. To give you kind of a little bit of an update of how implementation of compacts works, I'm not an expert, but I will give you a broad overview so that hopefully that's beneficial for you. In general, we are looking to join compacts to try and make things easier for providers to move across state lines. A compact, more or less, is a contract between states. Jennifer would probably correct me on that contract language, but that's broadly what it represents, is an agreement between states about how they're going to operate for specific things. In general, it is better for states to be involved early in the process. And that is because if you're involved early, you get to dictate the rules. And so what happens after the legislation passes and I'm just going to take it from the front, not a middle join, the commission will be set up, a compact commission will be set up, and that usually involves representatives from each state that has enacted the compact. There's specific language inside of the compacts. You've all probably read them before. They're very long and detailed. And usually those representatives will get together and they'll start to look at promulgating rules for how the compact is going to operate in the same way that our licensing boards and licensing programs promulgate rules. If you were curious about what things that they are specifically looking for, they're going to probably look at fees, application processes, public participation rules, and they'll also start to look at, and usually this is done before the legislation is enacted, they should have a pretty firm grasp on how they're going to address eligibility gaps. And the example that I'll give to you is from last session in 2025, the massage therapy compact known as IMPACT requires a minimum qualification of 625 hours for a massage therapist. And in the state of Montana, we require 500 hours. There's a 125-hour deficiency there. And so the way that that compact has come up with fixing that gap, because it's not a gap that's unique to Montana, is to allow practitioners to utilize continuing education to make up the 125 hours. Unfortunately, to get to the 125-hour verification, our staff here at the department has to ensure that that massage therapist has that additional time built in order to qualify for the compact for that specific one. So again, the commission will begin to promulgate rules. That's very similar process to the Administrative Procedures Act here in Montana. There's going to be public notice, time to comment, and then there'll be voting. And so they'll do all of those things. Simultaneously, one of the main things that compacts do is they facilitate data transfers or sharing, specifically for compliance issues. And so there's a technological development that goes along inside of that. Compact Connect, I think, is one of the main providers that several of the compacts use, but they all get to choose which kind of system they want to operate, and they have to get those things in place. And so broadly, to get the rules, the technology in place, and then to actually begin issuing privileges, if that's the way that compact is set up, because there are several different ways to set up a compact. You're looking at probably 18 to 24 months. after enacting the compact before the privileges begin to be issued. Back to the technological development, there's a component of that for not only the commission, but also for the state. And so the way that the state and DLI has interacted with compacts in recent years and will continue to do so is to use what's called a flat file for those of us who are not educated in technology, but it's a simple data transfer. It's not what I referenced previously, an interface between our licensing system and the Compact Commission's database. And the reason for that is we have very strong data laws in the state of Montana, and we want to limit the amount of information that is passed between the licensing bureau and the compact commissions. And that can also be a hangup too, because in general, we are having data sharing agreements with both the state and the compact commission, and those need to be hashed out as well. I'll give you an example. There's a compact that wants to have every single licensee's licensing information, regardless of whether or not they choose to be in the compact and get a privilege issued that way. We have a problem with that. We only want to share information for those people who want to be inside of that compact. And so those nuances inside that data sharing agreement and how things get set up as far as the exchange of the flat file to and from the compact commission take time. And so those are some of the things that we're working for. To give you just kind of an example, the counseling compact, which we in Montana passed in 2023, there are currently 3 states that are issuing privileges as of April 17th, 2026, Ohio, Minnesota, and Arizona. So if you're a person who moves frequently between those 3 states, that's very good for you. But since the other states aren't set up yet, the full impact of the compact won't be for probably another 6 months to a year, if I had to guess. And that includes our own state where we have to get our database programming up to speed as well. Again, since it's just a limited flat file, it's not as invasive. It's just getting those user agreement lined out, and then also revamping our current licensing database so that when people go in to either apply for an initial license, depending upon how the compact's set up, they can go ahead and do that process as opposed to having to come back and do that at a later time. We want to make that as seamless as possible. So that's kind of a broad overview of implementation. Again, 18 to 24 months is kind of the norm, and I hate to say that. Having said that, we are eager to join as many compacts as we can so that we can be involved in not only the rules process and those representatives, forgive me, I apologize, left off, that usually that is specified inside the compact as well. It's either a member of staff, a board member, or other specific representative for the state, maybe a governor appointee. And so those are the folks that are going forward. But we want to try and be involved early in those compacts, regardless of the lag time that we have to implementation. It's helpful for us to be involved in the process and the rules. It's also helpful for licensees because hopefully we can get these things implemented much quicker and we can start to get more providers into our state. And Aaron, I think I've gone on far enough. So I'm going to stop there and I'm happy to answer any questions anybody has.
Thank you so much. That was great.
Thanks, Kevin. Brad, you had your hand up?
Yes, Mr. Chair, thank you. Brad Longcake, Montana Dental Hygienists Association. I think compacts are going to be a critical thing moving forward, especially in the dental space and other disciplines. Like Mr. Webb stated, I think there are lots of bits and pieces that need to still be worked out and agreed upon, but look forward to the opportunity to kind of get into those discussions and finding ways to continue to help provide additional services, especially to these smaller communities across Montana, and we look forward to being part of that discussion. So I don't think we need to get into the minutia today, but just wanted to reiterate, I think, the importance and the value that this presents and our willingness to be part of that discussion. So thank you, Mr. Chair.
Appreciate it, Brad. Gail.
Thank you, Chair King. One thing that would be helpful to me is just a brief explanation of how you get to the point of requesting or hoping to be a part of a compact. Generally, does the idea rise up from an association of professionals Does the department ever recommend a profession that would benefit from being a part of the compact? And then, so kind of what steps happen before you get to the legislature with a request? And then what can the obstacles be in the legislature that would cause one to not be approved? Thank you.
Thanks, Chair King and Gail. I'll start the answer and then rely on my legal and licensing expertise that are on the call to pick up. So typically the ask will come from the industry, or sometimes it could potentially come from a board during discussions. But from what I've seen, at least, and the 5 that were enacted last session, I believe, all came from industry. So it wasn't the department that said we should join this compact. Not to say that couldn't happen, but it usually does come from the industry. And I know that we worked. So just for example, the compact's last session, we worked with the industry on the language and getting the language and reviewing it and making sure that it all tied in with Montana's standards before sending it off to the legislative services who do the drafting. But they they draft it from a technical point of view. They don't draft it from like any kind of advocacy point of view. So that's how it usually comes about. And then what was the question? Oh, the hiccups that could happen in the legislature. That every single bill has, proponents and opponents and informational witnesses. I believe that we, and Kevin would know this better than me, but I believe that we just came in as informational on all of the compacts last session, just to provide any kind of backup information to the legislature on what they, questions they had. But yes, Rep. Buttry should speak to this. Thank you, Webb. But the reason why a compact is passed or fails in a hearing, that is truly up to the conversations that happen and the testimony that is received from the proponents and the opponents. So I don't know if Jennifer or Kevin want to talk a little bit more about that, or if we want to pass it over to our faithful legislators that are on the call to talk about that process. That'd be great.
Chair King, if I might.
Please.
Thank you, Aaron. Chair King, I certainly want to hear from our legislators. At the same time, if you give me a microphone, I'll talk to you. Some of the things that we see that come up as potential downsides or things that may be viewed by legislators or other advocates as downsides of compacts have to do with the lack of a uniform standard. In general, most of our compacts nowadays are starting to cement those things as far as qualification, initial state qualification. Those standards are set by the states, and then the compacts will set a minimum level of entry into the compact, however it's set up. A lot of advocates will also say that there's an infringement upon state autonomy because it's an agreement between 2 states, and so there may be some issues there. The other thing that's always back of my mind, back to you, Webb, is funding. If we have a bunch of people who are state licensees who can now go and get a compact privilege, does that cut off revenue for the state licensing boards or programs? And so funding can be a concern as well. And then there's also been in the past, I think, some concern for tracking of individuals who are practicing in and out of our state, just based off how compacts are designed. I think those are probably 4 of the things that I would say come up quite frequently as far as why someone might not see a compact as beneficial.
Thank you.
Do we have any legislator that would wish to comment on this?
My hands
Senator
up.
Nolan.
Thank you. See, I think I'm unmuted. So from a probably 30,000 foot view, if legislation comes in and we're listening to a proposal that a compact is really questionable, one state may be more liberal, and there's nothing wrong with that. That's where people live. That's great. But then if we can't see that it's going to help us and there's a chance that it can hinder us. So it depends on the tightness of the compact. So when we get it and we see it and it's vague and we have too many questions, and I know a good expert on this is Representative Buttry, but we're going to shoot it down because if it's too many loopholes, it's not tightened up enough. It could go this way. It really doesn't help all the state of Montana. Too many people can go into the other states and they want to bring this in. They've got enough hours credited, but it's not tight enough for us. So we just say no, it isn't fixed. It isn't doesn't look apparently good for the entire state, and we just say too many loopholes. So unless it's fairly tightened, that my 10 years of doing it, that's what I have noticed regarding compacts. And I don't know if anybody else wants to comment.
Thank you all very much. That's helpful information. Thank you.
Thanks, Gail. I'll just do a shameless plug here that pharmacy has been really advanced on this, and we're actually changing the whole national test so that all pharmacists that take the national exam, any state that wants to join that will be allowed, and then the actual license transfer is very easy due to a switch put together by National Association of Board of Pharmacy. It's been a real exercise. I sat on a committee 14 years ago, I think, about pharmacy compacts, and Idaho put one together, but nobody joined it, so it's just still sitting there. But the solution that we found was to kind of open it up and make it easier for that license transfer portal to work itself. But it's a shameless plug. Maybe something others can look for. Okay,
So
Aaron,
I guess, yeah,
no, go ahead.
sorry, I didn't mean to interrupt you. I guess one question I will have for the subcommittee is that this is obviously the EMS compact is the one that the RHTP initiative one said that that would be part of the RHTP. And so I do want to have the EMS Compact Commission come and speak to this committee at the I think it's May 15th meeting. And I believe they have already agreed to do that. Amy, you can say yes or no if they have, or they're at least available. We have received an offer for this. Okay, yes, they have agreed. Thank you, Amy. For the social work compact, we have folks that are willing to speak on that one if the committee has questions. I guess my question for everybody is in preparation for the May meeting for this follow-up discussion and then possibly starting towards a recommendation. Are there other compacts that you want to get more details on that we have just outstanding? It's the APRN one, which Missy spoke to. The athletic trainers, there is cosmetology, which it's not part of this committee, but if you guys want to talk about it, you can. The dentist one, dentist and dental hygienist, I apologize. It's both of those occupations. Podiatry, which I believe the Board of Medical Examiners might be talking about the podiatry compact at next week's meeting. And then there's the social work one, and then not really relevant to this committee. Well, maybe perhaps school psychologists, but then the teacher compact's the other one. So are there specific ones, or do you want to, is there any additional information you want to see regarding any of those compacts, aside from the EMS one and the social work one, that I can prepare for the next meeting or try to get a speaker or at least somebody from, to be able to answer questions?
I see a comment from Allison Paul about social work, but I don't see any hands. Oh, Director Barrington.
Thanks, Tony. Hey, Aaron, even though the social work compact is not included in the Rural Health Transformation Program plan as a policy commitment, that is one that DPHHS would be interested in hearing about or learning more about through this subcommittee. So I would ask that that be added to the list as well.
Okay, great. Thank you.
Other recommendation. Do you have what you need, Aaron? Oh, Senator Nolan.
Say when we get to the, I think it's the time where public comment can come in, unless we have somebody that's available to talk now about the social worker, someone who wants to speak to that, so we can tighten up any issues that we might have there. I've had a few reach out to me that have moved from other states and said, this is what we've done over there. And I'm a little vague on the social worker issue. And I think we have a couple people on the committee that know about that. But if we have others that could chime in, and I don't know, Mr. Chairman, if you're gonna let them address it during the open mic time. But anyway, that's where I was wondering if we could do. So thank you.
Aaron, your thoughts on the social work topic?
So, yeah, thank you. We do have somebody from the social work compact or that's working on that, in the audience. They offered to present at this meeting, but I kind of just said, give an info sheet for now. And then when we readdress this topic in May, then maybe, they could speak, but it is up to you, Chair King, if you want. His name's Nathan Staley. I see him as an attendee. If you want him to speak now, but I haven't asked him to prepare anything for today.
I think May's fine if
Okay.
if it looks like the agenda allows. I think we can put it into May.
Okay.
If he wants to make some brief comments in the public comment period, I don't have a problem with that. We just need to be mindful of the other comments and time.
Right. Okay.
Okay.
Yeah, a big thing that I wanted for this meeting is to present you all with this information of these are the compacts that are available and links to the resources. And then knowing that there will be a follow-up discussion in May with experts that can specifically answer any questions that you have. So from what I hear, it sounds like the EMS compact and the social work compact are kind of the big ones. And then if potentially I can get somebody from CSG to attend the meeting in May to just answer any other questions in general about the other compacts, would that be helpful?
Yep.
Okay.
So. Committee members? Okay. I think we're ready to move on. We're going to wrap this up and then open it up for public comment. But agenda item number 3 is next meetings. Right now we're scheduled for Friday, May 15th at 9 a.m. And then to follow that, June 12th and July 17th. Any issues, any major glaring things that would make us need to move those around? I know we're going to be getting into the summer and we're going to be dealing with vacations. So again, appreciate your time and effort into this committee. Okay, Aaron, do you have anything on that one?
No.
Okay, I'll go into public comment. The subcommittee now offers the public in attendance an opportunity to comment on any public matter under the jurisdiction of the subcommittee that is not on the current agenda. While the subcommittee cannot act, but will listen to comments and may ask staff to place the issue on a future agenda, the chair may limit the comment period to proceed with the subcommittee meeting. As with most of these meetings, please share your first and last name, spell your last name for us, and maybe who you're affiliated with would help us when you're offering your comments. If you'd like to speak now, please raise your hand and we can move you into speaking. roll.
Chair King, did you want me to call on people or would you like to?
I can't see them.
Okay, I can do it. I can call
Sorry.
on them. We only have 2 right now. So again, if you do wish to provide public comment, please raise your hand and we'll call on you in the order that you raise your hand. So first is Nathan Staley.
There, found it. Mr. Staley.
Oh, where did he go? Oh, there he is. Okay. Sorry.
There we go. Chair, members of the committee, again, this is Nathan Staley. I'm the executive director for the Social Work Association across Montana, and I just wanted to provide a couple of comments and just say thank you again for all this hard work. I really appreciate being able to participate and listen in. So going back to, kind of early in the conversation around alternative pathways, I just wanted to flag one other alternative opportunity or idea. When we think about at least social work and other mental health professionals, behavioral health professionals, they have to go through a process of collecting hours and then taking the exam. That's traditionally kind of the pathway. And that's what most compacts, and again, the social work compact requires that. But there are some states who have considered alternative pathways that instead of taking or requiring you pass an exam, that you collect more supervision hours. So I know in Montana there are several social workers who have struggled to pass that exam for various reasons. And so some states are considering eliminating the requirement that you pass an exam and adding, I think it's twice as many supervision hours. So Illinois would be a good state to look at. It was House Bill 2365, and I'm happy to provide more information on that. But that could be just another idea to consider if you're looking for different alternatives. Then again, I just wanted to say thank you for the opportunity. I'm not going to speak to the social work compact, but I just wanted to kind of reiterate that, now is the time to join that compact. The commission is meeting, and I'm excited to present more details on our attempt to pass that legislation in 2025. And we really are intending to really button up any loopholes to make sure that we're ready to go. So I'm really excited to talk with you all about that. And then if you have questions, I'm here. So I just wanted to let you all know I'm really happy to participate, and I'll end there. Thank you.
Okay. Thank you, Mr. Staley. Aaron, I found it. So,
Okay, perfect.
Patty Steinmuller.
Yes. Hello, it's Patty Steinmuller, Steinmuller. I'm a registered dietitian. I'm on the Public Policy Committee of the Montana Academy Nutrition and Dietetics. And I'm just requesting an update to a number that's on the Licensing Task Force Healthcare Subcommittee, the license cost of licensure. On the page 11 on Board of Medical Examiners, it lists dietitian, and that number for a 0 is correct because we're HB 806 has been enacted, but rules are being in place to most of the dietitians are licensed as nutritionists. And that's the second item on that page. It says the numbers of licensees is 2. However, that needs to be updated. I don't know the exact number, but on 313, the healthcare license data request indicated there's 1,536 nutritionists licensed, and the number may be slightly different a month from March, but it's definitely that's where the registered dietitians are licensed as nutritionists now, and our license will change when HB 806 is fully implemented. So I just want to correct that there are many more than 2 nutritionists. And that's all I'm requesting that correction to be made.
Okay, thank you.
Thank you. We will get that document updated. Appreciate that.
Thanks.
Any other members of the public wishing to raise their hand to speak at this time? Seeing none, I just summary for future, just make sure, Aaron, if you just nod, we have on our list, or I'm probably gonna forget. I know we talked about in past meetings, the alternate to testing. I don't know, do we have that on our work plan?
For social workers, is that?
Well, it could be for others too, I guess.
Okay, yeah, I think that could be we can include it either in next month's discussion on expanding pathways, or we could include it when we circle back to administrative burdens, because that's a current licensing requirement. So either or, but I have made note of it, and I know that that was brought up before. So I guess wherever we have room to talk about it.
We have
If there
social
are,
work.
but again, I'll make this ask that if there are other examples that can be provided, so we're maybe narrowing our focus a little bit and coming up with some real solutions and recommendations, that would be helpful. If anybody has any, you don't have to say it now, but just get in touch with me if you know for sure that exams could be a hindrance.
Okay. We have social work compact. I don't know, Mr. Longcake brought up the dental hygienist. Trying to think what else in the last 3 meetings that we've discussed, make sure we cover them all. We will circle back on the new yes, the nutritional aspect for MDDOs. You have what you need. I'm just trying to make sure you have what you need, Aaron.
I'm good. Yeah,
Okay.
I'm good.
Okay. I think that's it for today. Again, appreciate everyone making it to the meeting and being really participative in the last 3 meetings in a week. Look forward to what we can do coming up here in May. If you have anything else that you need, please reach out to myself, co-chair Etchart, or Aaron, and we'll see what we can do to make sure your topic is covered. But with that, I will end the meeting. Have a great weekend, everyone, and we'll be in touch soon.
Thanks, everybody.